I must congratulate the scientific planners to have included familial hypercholesteremia in the talk, because when we have a patient in front of us, we are talking only about one case who is sitting across you. But when we talk of a family, we are actually going to go through people who are not even affected, but just because they are related to the person who is affected. And so a lot of them get going to get a preventive care. So we have two kinds of familial hypercholesteremia, the familial homozygous and familial heterozygous, and we'll see the differences as we go on. It's defined as a heritable occurrence of severe hypercholesteremia. It's not just small rise in LDL, but it's a huge rise in LDL. And actually there are Nobel Prize winners for detecting the LDL receptors on liver cells and the relation to familial hypercholesteremia. The heterozygous and homozygous, these are the two different varieties. And the homozygous, actually they are rare, luckily, and the incidence is much less compared to heterozygous. So heterozygous are 1 in 350, while homozygous are 1 in almost 500,000. So this is obviously a very risky proposal, as we can see in the next few slides. You can see here the homozygous has a very high LDL, 460 plus. The triglycerides are generally not very high. You have cutaneous tendon xanthelasmas and other xanthelasmas, but tuberous xanthelasmas and planar xanthelasmas, they are common with homozygous. And the presentation is possible before age 20 years, while most of these are 40 years and around. What I'm trying to say is the heterozygous is a sort of a common presentation. Many would come to you around age of 50, 45, and you would treat that particular individual. So in effect, we could be missing these. When you have somebody who is 15 and coming to with a coronary blockage, you know that you are definitely dealing with something very critical. But these may be passed off as a routine case, and we could miss a very good chance to treat them. So the homozygous could be symptomatic since childhood. The normal triglyceride is probably a feature of both. And the important thing to remember is the homozygous, they respond poorly to medication, while most of the heterozygous will respond to medication. So this is again, you give statin to anybody who is around 50, there is a response, and you possibly do not look for heterozygous familial hypercholesteremia in those who are presenting around age of 40 and 50. These are the physical signs which you should look for. So if you have these physical signs, then the arcus coming at a very early age, you have somebody who is 15 years and you see an arcus, you certainly think of a familial high cholesteremia. Most of the time it's homozygous familial hypercholesteremia. So how do you diagnose familial hypercholesteremia? The FH stands for familial, and there are these family history, clinical history, physical examination as we mentioned, and importantly LDL levels. So all these are important. They are given a particular score. You pick up the score and you say a definite familial hypercholesteremia if your score is above 8. You say it is probable if it is between 6 and 8, and possible if it is between 3 and 5. So this is how you sort of suspect. It's not necessary. I'm going to come to 2 other tests. Normally we do lipid profile, but we have what is called as a cascade screening, and we have what is called as a genetic testing. So all these are actually making a diagnosis of familial hypercholesterolemia. I'm just showing you one example. This was a girl, I used to go as an honorary to one of these hospitals, and the resident doctor showed me an ECG. He didn't show me who is the patient, but just showed me ECG at rest. And then he had made the patient walk a few times up and down the staircase, and then he had taken another ECG, and they were huge ST depressions. And then he told me, what do you think? I said, it's like a stress test, done very crudely. He had made the patient go up and down the steps. So this was a very strong positive test. And then he brought this girl in front of me. She was just about 11. And she had these critical blocks in the left main and one in the LAD. So this was years ago, and then we did a 2-vessel stenting for her. Many years later, she was actually giving an interview, which was translated, of course, to a meeting from Goa, which was getting transmitted to New York. And this was the first youngest left main stenting that the world had witnessed. She lived very well for many years, from 11 to 25 when she presented again. And this time she had a lesion at the mouth of the left coronary and another lesion at the mouth of the right coronary. So we had to put two more stents for her and correct these defects. She went for another 3 years. Finally, she died. She had something like a ischemic dilated cardiomyopathy, severe mitral regurg, and the death was sudden in one of the malls in Delhi. I presume it was sort of a death due to sudden cardiac death due to a major arrhythmia. But look at what her score is. You have an LDL going down from here, and you can see all the time the LDL was above 400. And what we have used initially, we used atorvastatin 40, then we have added atorvastatin ezetimibe. This continued, but you can see there was no drop in LDL cholesterol. This was changed to actually rosuvastatin, initially 40 and then 80 milligram, and yet there was no change in her cholesterol values. This was her sister, who was about 2 years older, and she had this was the aortic valve, which was really thick in her case, but not obstructive. But above the aortic valve, there was a supravalvular calcific membrane. Now this calcific membrane is a chunk of calcium which sort of over a length of time, maybe years, the cholesterol getting converted into calcium. So many of these would present with supravalvular aortic stenosis, and she also needed surgery for this, as well as she needed a coronary artery bypass graft. So 2 sisters, one at 11 and one at 17, needed a major cardiac intervention. So these are actually severe vascular diseases coming at a very early age, the homozygous, and numerous cases need CABG, and they also have early deaths. As I mentioned, severe aortic stenosis, it may be valvular or it may be supravalvular in our case, and they also have a lot of deformities like abdominal aorta, aneurysm, and so on. This is actually our Pallavi, which was our patient's, her mother. Now she has no symptoms, she has a negative stress test, so you can say she has no evidence of coronary artery disease, but the cholesterol LDL was 143 total cholesterol was 290. Triglyceride was normal. So she's on large dose statin. We have been able to achieve just about a mild reduction in this. These homozygous, they get transmitted through the mother and through the father. And those who get transmitted from the mother, they probably have a more severe kind of familial hypercholesterolemia. And they are affected, possibility is quite sizable, 25% of either a male or a female child would be affected. What is important is years when the patient meets CVD threshold. As Dr. Bridgemohan mentioned, don't think of stopping the LDL reducing therapy for anybody who is at an event. It should be a lifelong pattern. The others you may judge, like initially you may give a 20 milligram, come down to 10 if there are responders and they have no benefit. The slides are gone. So you need to be quite controlled on the therapy that you're using. Also, the duration becomes very important. Those who get it early, you must give them for a longer length, and only if you give for a longer length, you see more benefit. Yes, certainly. Actually, her sister, we have put her on PCSK9. Actually, the mother works in that hospital as a jhadu kamgar. So it's very difficult for her, but we have managed to get some funding for her. So the sister is now on PCSK9 inhibitor. Hopefully the mother also should get it, but I think it's cost really prevents. I have a talk on the PCSK9 inhibitors in another 20 minutes time. So maybe we'll talk more about that during that. Yes, in fact, I'm just waiting for the slides to come up because my next case is one which actually this boy was actually Dr. Ramesh Damle's patient. He had a bruit on the abdomen and severe hypertension. We'll come to that, but this is how it is. This is 20 years. Patient can present later, and this later presentation would look like a generalized atherosclerosis. You will start blaming smoking, obesity, no exercise, etc., when truly the patient could be a case of familial heterozygous hypercholesterolemia. So it's very easy to miss the heterozygous, but the homozygous comes here, and I think all of us would be smart enough to pick up the homozygous one very easily. So this is the case I was, Dr. Niranjan was asking. He came for bruit on the abdomen. Smart thing was to pick up the bruit because most of us don't auscultate abdomen. But he had hypertension at a very young age, something like 12, 13 years. And this was done when I was an honorary in Sassoon. You can see the abdominal aorta from this point to this point is narrowed, not critical, but you can see this is like an aortoarteritis. And you have bilateral renal artery stenosis. Most of us, and even at that stage, even we thought this was a conventional aortoarteritis, and we treated him on those lines. We give steroids and things like that, check ESR, C-reactive protein, etc. But this turned out to be severe familial hypercholesterolemia because his father, who was just about 40, 41, came with an acute infarct. In those days, we were not even thinking of doing lipid evaluation for these kind of cases. This was soon after I finished my DM and I came to Pune and I was working in Sassoon. So that's around 83, 84. This boy actually, as you can read here, he presented at age 8 years and had a sudden death at age 13 years. We did a postmortem on him because I think those days angiography, etc., was not very easily available. But he had severe coronary artery disease, dilated heart, so there was pan-atherosclerosis across every vessel. So these are the two brothers. The third one is missing because he sent these two brothers to me to get their arteries fixed, and he had got his fixed earlier. So they would generally present at this age about 40ish, but multiple lesions. All three of them were advised bypass surgery, and all three of them were done with an angioplasty. I strongly believe that angioplasty should be a better option for younger individuals compared to older. And this was actually the first patient in the world who had left main stent in stent. Actually, in those days, left main lesions, always a bypass surgery. But that was the only lesion, and we had no drug stents available that time. So we offered him a bare metal stent. I mean, fully knowing, we had actually told him go for surgery. Predictably, he came back, and second time also we told him now go for surgery. But he didn't accept it. We had just about got the Cypher, the world's first drug stent available to us. And we did second angioplasty in the same site. Today it's about 20 years and more, and he's doing fine. He works as a professor in some college in Bombay. So we have this familiar genetic testing. There are some clinical criteria. These are different people giving them. So Siebenbrum is generally accepted criteria. All of them will have a high LDL, something like 190. And again here, definite diagnosis of familial hypercholesterolemia requires either A and one of B or C, and probable would be A and one of D and E. So this is how you diagnose familial hypercholesterolemia. No, this is actually a mutation of LDL receptor. So you would get different kind of mutation. In fact, there are 3 major mutations, but multiple mutations of all these 3. And based on that, you would get different kind of diagnosis. So the clues that would help the diagnosis, of course, a family history, physical examination, lab values, of course, and response to treatment. If you're finding it difficult, the response, I think it's very difficult. I mean, you should be thinking of these. Can I get a couple of extra minutes? I mean, we lost some time. This is actually a friend of mine, Dr. Sawni from Delhi, and he picked up great interest in familial hypercholesterolemia. So this is done in Gangaram Hospital, and 40% of his patients were diabetic. ARCUS was seen in 62 cases, which was again 58%. And these patients had cascade screening. The whole family was screened, as well as the genetic screening which was used. So what should be the goals of therapy? Most of the time, the rule of thumb is try to cut the LDL value by 50%. That means if somebody has 400, at least try to bring it to 200. We, of course, like to get to less than 100. Lower is better, as you heard earlier. So less than 70 should be our LDL goal. So those who have event, you must come down to less than 70. In children, you may, since this familiar comes very early, many of the children, the father or mother, they would just bring you the report. Child is not brought to you, and child may be healthy. And in these cases, your target should be 135. When you start statins in children, you should start in a smaller dose, not the usual adult dose that you give. And you can make out from these studies patients with heterozygous familial hypercholesterolemia. As I've been telling you again and again, this is a little bit difficult to suspect, so you must remember the ESC guidelines where to sort of suspect and cascade screening. That means you have one fellow in front of you, you check the entire tree. What about treatment? Most of the time it would be statin. Second we add is ezetimibe. And of course, PCSK9 inhibitor comes very close to that in these ESC guideline. You can see similar type and for children, of course. And you can start very early, 8 to 10 years. But in my personal discussion, many have agreed that it could be even earlier. So statin therapy under the age of 5 years is also allowed in these kind of patients. Now the other testing we do is the genetic screening, not recommended for everybody, but the genetic screening will have its own role. You can see statin, ezetimibe can bring it down, but PCSK9 becomes very important. You must continue this therapy. Don't stop. If you want, this is the acute slope, people dying early age. You must slow down the slope so that people can go to beyond 60 and 70 in a healthy fashion. So must start good therapy. The response in Odyssey with LDL is, you can see here, substantial drop. This was documented in 4-year by the evolocumab. So this kind of drop is very important, but always remember that you must maintain it over a long length of time, then you can truly reduce the events. So genetic testing, not crucial for everybody, but more than 80% of the familial hypercholesterolemia patients have LDL mutation. Genetic testing can actually give us more patients, because we are picking up patients who are not suspected to have coronary artery disease. The interpretation of this particular study was a single measurement of cholesterol clearly underestimates the true lifelong exposure to cholesterol. Many of these have exposures intrauterine, so they are exposed to high level even when they are in the womb. Most of us do these family screening, like a cascade screening, do for everybody who comes at an early age and start the treatment at an early age. I've had some patients where both parents have been affected around age of 55. They bring the son who is 15-year-old with an LDL which is high. Many times you want to say, oh, he's playing nicely, growing up, playing games, he's very healthy. But I'm sure these are the cases of familial hypercholesterolemia, maybe heterozygous. The testing of this nature, it should be done for many reasons, but diagnosis of familial improves the medical care and compliance. I think I'll stop here. I had a few slides. If you see India's incidence is less than 1%, which is unbelievably low. And this is primarily because we are not looking into familial hypercholesterolemia. So we don't ever find an individual in familial hypercholesterolemia, but we are finding a family. So let me end by saying that you are doing a great service to the society. When one patient is coming to you, he may be just diabetic, but you are picking up 20 people around him who are potentially candidate for whatever therapy you choose. you could save them from getting into events. So this is familial hypercholesterolemia is underdiagnosed. Identification of high-risk subjects is very crucial. There are clinical scores. Most of us go by clinical scores. Like somebody comes with an LDL of more than 200, we would definitely suspect a familial hypercholesterolemia. But we have, we do cascade screening in these, but we have genetic testing, not easily available, but they can certainly add and contribute to the benefit of therapy for all these individuals. Thank you indeed for your attention.